In this chapter, you will learn ICD-10 guidelines. We're not going to go over every guideline together, but I'm going to show you how to find them and how to identify the guidelines that are important. Find your guidelines in your ICD-10 book. Every book's different if it's published by a different publisher. If you have an AAPC version, it'll be in the back of the book for 2018. So what I want you to do is to tab this so you can easily go to it when needed. Also, I want you to get a special color highlighter and go through and highlight the chapters. We're going to talk about how to reference your guidelines. This could be a random question. At the beginning of your guidelines, there is a table of contents. I have it highlighted with my sections in yellow, the subsections in green, and the chapters in purple. So here's how you reference it. Section 1 would start with I, and if you were going to conventions, it would be .A, and if you were doing the alphabetic index, it would be .1. The main area where you'll be spending most of your time learning these guidelines is in the chapter-specific guidelines. Let's look at Chapter 1. Turn to that in your guidelines. Chapter 1, A, is Human Immunodeficiency Virus, HIV. Here are the guidelines for that. Number 1 is coded-only confirmed cases. Confirmation does not require documentation of positive serology. The provider's diagnostic statement is HIV positive or has an HIV-related illness is sufficient. The main part is sequencing HIV codes. Before we go into sequencing, I want everyone to know that once a patient has been diagnosed, an HIV code should be on every claim for that patient for the rest of their life. It is the sequencing of the codes that may change. Sequencing depends on the reason for the patient's encounter. So let's go over that. The guidelines state if the patient is admitted for an HIV-related condition, that B20 for HIV should be coded first as the principal diagnosis, and the HIV-related condition should be second. If a patient is admitted for an unrelated condition, the unrelated condition is coded first, B20 is coded second, and the HIV-related condition, if there is one, is coded third. An example of this is if a patient is admitted for an ankle fracture, the ankle fracture would go first, B20 second, and any HIV-related condition third. Asymptomatic, meaning no symptoms of HIV, should be coded with Z21. Asymptomatic human immunodeficiency virus status is to be applied when the patient without any documentation of symptoms is listed as being HIV positive or known HIV or HIV test positive. Do not use this code if the term AIDS is used. That would mean the patient is not asymptomatic and B20 should be assigned. Notice how on my guidelines I put notes so that I could easily see the sequencing. You should do this throughout your entire guideline section when it talks about sequencing. It will help you when you're quickly trying to find an answer. So let's go over the HIV codes. Like I said, B20 is for symptomatic HIV patients. R75 is for inconclusive laboratory evidence of a human immunodeficiency virus, HIV. Z20.6 is contact with and exposure to HIV. Z11.4 is for encounter for screening for HIV. This would be used if someone's coming in to be tested but does not have a confirmed case. Z71.7 is HIV counseling. Z21 is asymptomatic HIV. Z21 is used when the patient has a positive test but does not have any symptoms of HIV yet. Once the patient becomes symptomatic and B20 starts to be used, that is used for the rest of their life. HIV infection in pregnancy. O codes are for OB. That's how I think about it. And they always have precedence over any other code. We'll go over that more when you read the guidelines for that section, but just know that if the patient is HIV and they are pregnant, the Principal diagnosis or first diagnosis should be 098.7 and then B20 and then any associated related illness to HIV. If a patient is being seen to determine his or her HIV status, Z11.4 should be used. If a patient with signs or symptoms is being seen for HIV testing, code the signs and symptoms and then code Z71.7 for HIV counseling. Now let's look at C, infections resistant to antibiotics. Many bacterial infections are resistant to antibiotics. It is necessary to identify all infections documented as antibiotic resistant. Assign code Z16 for the resistance of antibiotic drugs. This would follow the infection code only if the infection code does not identify drug resistance. Sepsis, severe sepsis, and septic shock. Sepsis, for the diagnosis of sepsis, assign the appropriate code for the systemic infection. If the type of infection or organism is not further specified, assign code A41.9. A code from subcategory R65.2, severe sepsis, should not be assigned unless severe sepsis or an associated acute organ dysfunction is documented. Sepsis with organ dysfunction. If a patient has sepsis and associated acute organ dysfunction or multiple organ dysfunction, MOD, follow the instructions for coding severe sepsis. Let's talk about severe sepsis. Make a note that there should always be two codes when coding severe sepsis. First, the code for the underlying infection, followed by the code from subcategory R65.2, severe sepsis. If the causal organism is not documented, assign code A41.9, sepsis unspecified organism. Septic shock. Septic shock generally refers to circulatory failure associated with severe sepsis, and therefore it represents a type of acute organ dysfunction. For cases of septic shock, you will first code the infection, followed by R65.21 or T81.12. Sequencing of severe sepsis. When severe sepsis develops during an encounter and it was not present on admission, the underlying infection and the appropriate code from subcategory R65.2 should be assigned as secondary diagnoses. If severe sepsis is present on admission, it should be the principal first diagnosis. Sepsis and severe sepsis with a localized infection. If the reason for admission is both sepsis or severe sepsis and a localized infection such as pneumonia or cellulitis, a code for the underlying infection should be assigned first, and the code for the localized infection should be assigned as the secondary diagnosis. Now let's talk about MRSA. There are combination codes for MRSA. When a patient is diagnosed with an infection that is due to MRSA, and that infection has a combination code that includes the organism, such as pneumonia, assign the appropriate combination code. The condition or state of being colonized or carrying MSSA or MRSA is called colonization or carriage. While an individual person is described as being colonized or being a carrier, colonization means that MSSA or MSRA is present on or in the body without necessarily causing illness. A positive MRSA colonization test might be documented by the provider as MRSA screen positive or MRSA nasal swab positive. Assign code Z22.322, carrier or suspected carrier of MRSA for patients documented as having MRSA colonization. Assign Z22.321 for MSSA colonization. Now let's look at a question together so you can see how you're going to apply these guidelines and know when to go look at them. A confirmed HIV positive patient who presents to the clinic for a medication refill for a condition not related to HIV, what ICD10 codes are reported? You would look in your ICD10 guidelines and see that if a patient is being seen for a condition not related, that reason should be coded first, followed by the HIV code. Medication refill would be coded first. Then Z21 would be coded second because it is HIV positive and there was no mention of AIDS or symptoms of the HIV. B would be your answer. Now we're going to take a look at Chapter 2 for Neoplasms. Let's start with B, treatment of secondary site. When a patient is admitted because of a primary neoplasm that has metastasized and the treatment is directed toward the secondary site that it metastasized to, the secondary neoplasm is designated as the first principal diagnosis, even though the primary malignancy is still present. Management of dehydration due to malignancy. When an admission or encounter is for a management of dehydration due to malignancy and only the dehydration is being treated, the dehydration is sequenced first, followed by the codes for the malignancy. When a primary malignancy has been previously excised and there is no further treatment being directed to that site and there is no evidence of any existing malignancy, a code from Z85 personal history of malignant neoplasm should be used instead of the neoplasm code. Admissions, encounters involving chemotherapy, immunotherapy, and radiation therapy. When an episode of care involves the surgical removal of a neoplasm, primary or secondary site, followed by an adjunct chemotherapy or radiation treatment during the same episode of care, the code for the neoplasm should be assigned as the principal first listed diagnosis. Go through the rest of Chapter 2 and make your notes and highlights. Now we're going to go over some other main guidelines. Turn to the diabetes section. Type of diabetes not documented. If the diabetes type is not documented in the medical record, you must default to type 2, E11. Diabetes and the use of insulin. If documentation in the medical record does not indicate the type of diabetes, but indicates the patient uses insulin, code type 2 diabetes should still be assigned. An additional code should be assigned as well from category Z79 to identify long-term use of insulin. Like I said, we're not going to go over every single guideline, but we are going to go over the main ones. So in Chapter 5 for mental, behavioral, and neurodevelopmental disorders, we're going to actually just look at 2 for psychoactive substance use, abuse, and dependence. This guideline is pretty important when the provider documentation refers to use, abuse, and dependence of the same substance, such as alcohol, opioid, or cannabis. Only one code should be assigned to identify the pattern, not all. So how do you choose which code to use? The guidelines say if a use and abuse was documented of a substance, only assign abuse. It takes hierarchy over use, obviously. If both abuse and dependence are documented, assign only the code for dependence. Dependence takes precedence over abuse. If use, abuse, and dependence is documented, you only code dependence. If both use and dependence are documented, you only code dependence. So as you can see, dependence is the worst. So if that is ever documented, that needs to be coded instead of use and abuse. Now let's look at Chapter 9, diseases of the circulatory system. You should know, with hypertension, there is a causal relationship between hypertension and heart involvement, and between hypertension and kidney involvement, as the two conditions are linked by the term with in the alphabetic index. These conditions should be coded as related even in the absence of provider documentation, unless the documentation clearly states the conditions are unrelated. For hypertension and conditions not specifically linked by relational terms such as with, associated with, or due to in the classification, provider documentation must link the condition in order to code them as related. Let's look at hypertension with heart disease. Hypertension with heart conditions classified to I50 or I51.4 series or I51.9 series are assigned to a code from category I11, hypertensive heart disease. Use additional codes from category I50, heart failure, to identify the types of heart failure in those patients with heart failure. The same heart conditions with hypertension are coded separately if the provider has specifically documented a different cause. Sequence according to the circumstances of the admission encounter. On your codes, it will say code also or code first. This will help reference you to this guideline. Now let's look at hypertensive chronic kidney disease. Chronic kidney disease has the acronym CKD. Assign codes from category I-12, hypertensive chronic kidney disease, when both hypertension and a condition classifiable to category N18, chronic kidney disease, are present. So, in other words, you wouldn't code the hypertension and the chronic kidney disease separately. Instead, you would use a code from category N18. The appropriate code from category N18 should be used as a secondary code with a code from I-12 to identify the stage of chronic kidney disease. And it is referencing the guideline for chronic kidney disease. If a patient has hypertensive chronic kidney disease and acute renal failure, an additional code for the acute renal failure is required. Hypertensive heart and chronic kidney disease. Assign codes from combination category I-13 when there is hypertension with both heart and kidney involvement. If heart failure is present, assign an additional code from category I-50 to identify the type of heart failure. The appropriate code from category N18, chronic kidney disease, should be used as a secondary code with a code from category I-13 to identify the stage of chronic kidney disease. Hypertension secondary. Secondary hypertension is due to an underlying condition. 2 codes are required, one to identify the underlying condition and one from the category I-15 to identify the hypertension. Sequencing of the codes are determined by their reason for admission. So if it was for the hypertension, that would go first. Or if it was for the etiology or the underlying condition, that would go first. Hypertension should be specified as controlled or uncontrolled. Number 8, hypertension controlled. This diagnostic statement usually refers to an existing state of hypertension under control by therapy. Assign the appropriate code from categories I-10 through I-15. Uncontrolled hypertension may refer to untreated hypertension or hypertension not responding to therapy. In either case, assign the appropriate code from categories I-10 through I-15. Chapter 12, Diseases of Skin and Subcutaneous Tissue. These are L codes. First, there's a guideline on pressure ulcers. Pressure ulcers are coded based on stages. Code from category L89, pressure ulcer, identify the site of pressure ulcer as well as the stage of the ulcer. The ICD10 classifies pressure ulcer stages based on severity, which is designed by stages 1 through 4, unspecified stage and unstageable. Unstageable pressure ulcers. Assignment of the code for unstageable pressure ulcer should be based on the clinical documentation. These codes are used for ulcers whose stage cannot be determined. It's not that they aren't determined, it's that they cannot be determined. Example, the ulcer is covered by eschar or has been treated with a skin or muscle graft, and pressure ulcer that are documented as deep tissue injury but not documented as due to trauma. This code should not be confused with the codes for unspecified stage. When there is no documentation regarding the stage of the pressure ulcer, assign the unspecified stage. Patients admitted with pressure ulcers documented as healed. If the pressure ulcer is documented as healed, no code is assigned. Patients admitted with pressure ulcers documented as healing. Pressure ulcers described as healing should be assigned the appropriate pressure ulcer stage code based on the documentation in the medical record. If the documentation does not provide information on the stage of the healing pressure ulcer, assign the appropriate unspecified stage. Now let's go to Chapter 13, the musculoskeletal system. The main thing, you have your site and laterality. So that's where it is on the body and what side of the body. Then you have acute traumatic versus chronic or recurrent musculoskeletal conditions. Many musculoskeletal conditions are a result of a previous injury or trauma to a site or are recurrent conditions. Bone, joint, or muscle conditions that are the result of a healed injury are usually found in Chapter 13. Recurrent bone, joint, or muscle conditions are also usually found in this chapter. Any current acute injury should be coded to the appropriate injury code from Chapter 19, which we'll go over later. Injury codes are not coded from this section. Chronic or recurrent conditions should generally be coded from this chapter. So pathological fractures should be coded from this chapter because a pathological fracture is not an injury. Seventh characters are still required for pathological fractures, and on the code you will see the seventh character icon. The seventh character A is used as long as the patient is receiving active treatment. I don't want anyone to get confused and think you should just use A the first time the patient is seen. If the patient is actively being treated for that pathological fracture, the A should be used. After the A, the character D should be used in subsequent encounters, not on the same encounter. The seventh character D is used for encounters after the patient has completed their active treatment for the fracture and they are just coming in for follow-up visits to see the healing. Chapter 14, Diseases of the Genitourinary System. Chronic kidney disease. Stages of chronic kidney disease. The ICD10-CM classifies CKD based on severity. The severity of CKD is designed by stages 1 through 5. Stage 2, code N18.2. This equates to mild chronic kidney disease. Stage 3, code N18.3, equates to moderate CKD. And stage 4, code N18.4, and this equates to severe CKD. Code N18.6 is end-stage renal disease, which is ESRD. That's a good acronym to write down. If both a stage of CKD and end-stage renal disease are documented, you should only code the end-stage renal disease. Now,